So we're going to move now to the second presentation, and it's my pleasure to introduce Dr. Tan Ngoc from Vietnam. She's going to share with us a case on atypical angina. And again, we're going to have the same format. Dr. Tan will present the case in about 15 minutes. Then we'll have some about 10 minutes for discussion. And then we will have the panel discussion at the end with all the speakers and also with the audience. So please, Dr. Tan, the floor is yours, or the screen is yours. Thank you so much.
Yeah, hello everybody. I'm Dr. Thé from University of Medicine and Pharmacy at Ho Chi Minh City in Vietnam. Today is my great honor to be here in this APEX program to present a case, angina equivalent case, so that we can have some discussion about how to approach, to have the appropriate approach of its diagnosis and treatment. Yeah. I can't move. Okay, so let's start with the patient information. This is a 66-year-old female patient who has been retired for 10 years, and she came to see me because of her nocturnal shortness of breath. And upon history taking, she reports a feeling of short of breath during sleepy at night, which wakes her up, not every night, but with a frequency of 2 or 3 times per week, which affects her quality of sleep and make her a little bit worried. She denied any chest pain or palpitation during neither her bout of dyspnea nor daily activities. About her past medical history, she is hypertensive. She has dyslipidemia, obesity, diabetes, and microalbuminuria. She has had a sedentary lifestyle, and her current daily medications has included a fixed dose drug combination of anti-hypertensive and anti-hyperglycemic, and she is under statin therapy also. In terms of clinical findings, we see she is obese with the BMI is 29.3. No other signs on clinical examination, and with the normal heart rate, beat regular, and normal range of blood pressure. We, based on her history and her clinical finding, we carry out some baseline investigation, and the result came back with the normal full blood count, normal electrolyte panel, normal liver, renal, thyroid functions. Her diabetes was well controlled with the FDS 154 and A1C is normal 5.6. In terms of her dyslipidemia, she has the high LDL cholesterol 142. We also indicated the anti-proBNP to investigate her nocturnal dyspnea, and the result is normal. In addition, she has a microalbuminuria and a high albumin to creatinine ratio. Yeah, and the EKG on that day show regular sinusal rhythm, no specific ST depression at the V5, V6, and D1 and AVL. Electrocardiogram show no left ventricular hypertrophy. She has the very mild aortic regurgitation, no pulmonary hypertension, no regional wall motion abnormalities, and normal ejection fraction. X-ray of the chest is normal, and there is the fatty liver on the abdominal ultrasound. My first question is, which test we can choose for diagnosing her symptom? We have 4 options: stress EKG, stress echocardiography, CCTA, or invasive coronary angiography. To answer this question, I think we should let's start some review, some guidelines. I would like to go through the guideline in 2021 of AHA. And in this guideline, there are 10 take-home messages for the evaluation and diagnosis and treatment. But the first message is chest pain means more than pain in the chest. And the shortness of breath, like our patient, should be considered angina equivalence. And in these 10 messages, I would like to emphasize, to highlight another thing. The second woman may be more likely to present with accompanying symptoms. And we should to remember to use the clinical decision pathway and try to identify patients most likely to benefit from further testing. And let's go with the ESC guideline. Our patient didn't have the traditional clinical angina symptoms. She complains with dyspnea. Based on her dyspnea, her age, and her gender, the PTB, the pretest probability of obstructive CAD is 14%. And with this PTB probabilities, I think the testing for diagnosis may be considered after assessing some modifiers of PTB. Yeah, and look at here. Our patient has some PTP modifiers like dyslipidemia, diabetes, hypertension, which increase the clinical likelihood of CAD, so that she should has a further investigation like coronary CTA. Based on the guideline of HHA, the CCTA also favor for the patient with less obstructive CAD suspected, like our patient. Another reason to choose a CCTA for our patient based on the study done by Discharge Trial Group. In this study, we can see CCTA and invasive coronary angiography have the similar predictions of CV events. But with the CCTA, there are fewer procedure-related complications. So that we did the CCTA for our patient, and this is the result. We can see there is the insignificant stenosis, less than 50% in 3 vessels. And there is also the myocardial pressure at the middle of LAD. So my next question, based on the result of the CCTA, what is her diagnosis? Is an angina equivalent and with the INOCA, that means ischemia with no obstructive coronary arteries. We know that obstructive coronary artery disease was defined as the presence of at least one stenosis more than 50%. And the non-obstructive coronary artery disease was defined as the presence of less than 50% lesion at least one epicardial artery. Yeah, so based on the CCTA and her angina equivalent, let's go through a little bit about mechanism of myocardial of INOCA. And we can see there are 2 phenotypes of INOCA with coronary microvascular dysfunction or vasospastic angina. And here is some criteria for microvascular angina. Our patient has the dyspnea and the non-obstructive CAD on the CCTA, and we should have a further investigation to have the definitive diagnosis of INOCA. But unfortunately, our patient refused further investigation. So her final diagnosis is still angina equivalent with suspected INOCA with the non-obstructive CAD 3 vessel. My next question is, what's the prognosis? And the risk of CV event of this patient vary depending on the score or the algorithm we use to evaluate the risk of CV event. Whatever score we use, this patient has the intermediate to high risk of CV event in the future. And one thing I would like to emphasize here is for the free vessel non-obstructive CAD carries a worse outcome compared to OCD. You see in the picture. Yeah. So what is the treatment? Is my next question. Yeah. And here is some components of management of INOCA. We should have some lifestyle changes, risk factor management, and anti-angina medication. These medications, sometimes we should combine or use it simultaneously. Yeah, and my treatment for this patient, I increase the dose of statin. I add the bisoprolol, the long effect nitroglycerin, and the trimetazidine for this patient. And I also ask the patient to keep the diary of the angina or the dyspnea, and ask the patient come back 1 week later. And 1 week later, the patient just reports only 1 bout per week of nocturnal dyspnea, and we can see her heartbeat more than 83 per minute. And the question is, should we have any changes in prescription? Based on her heartbeat, I increase the bisoprolol and I add the ivermectin for this patient. And that is, I would like to end the case with the follow-up 2 weeks later. Yeah, and of course, I will follow up very strictly the patient with the diary of the dyspnea or angina in her symptom. So what can we learn from this case? I think firstly, we should think about the anginal equivalent if the patient have some complaints about some dyspnea. And based on the real life setting, sometimes it's not easy to have the definitive INOCA diagnosis. And I think INOCA should be recognized as a clinically important entity in daily clinical practice. And a systematic approach to diagnose and treat this patient should be implemented. Yeah, and I would like to show some take-home figure here with the non-invasive evaluation, invasive evaluation, and the components of management of INOCA. So any comments or questions should be very appreciated. Thank you for your listening, and we can come back with Professor Pinto.
Thank you so much, Dr. Tan. Very nice case, very illustrative, a very pedagogic case also, with very well studied. And we have now time for a little bit of discussion and a couple of questions before we move into the more general discussion. And your case shows very nicely how an angina equivalent as dyspnea can really be important in this in understanding better these patients and being alert for this type of symptoms. And that's something that until recently many people will not pay too much attention to that. But actually, as you have nicely shown in the new ESC guidelines, or in the last ESC guidelines, that is now included. And even the table that you showed with the probability pre-test, now including also dyspnea as one of the elements. So my question to you is regarding this inclusion of dyspnea now as an angina equivalent, which we knew, but was sometimes not so much taken into account. You know, how do you think that can actually change the way we are approaching these patients? Because we are used to talk about chest pain, about chest discomfort and those things, but now dyspnea is also considered as an important symptom, even if there is no chest pain. First of all, in your experience, do you have many of these patients, or it is more sort of a rare finding that you find in only a few patients? And second, from the perspective of managing these patients from a diagnostic standpoint, well, you showed nicely our example, of course, but what do you think should be the first test to do to a patient who presents like this? What's in your view, or tests or studies that should be done in these patients who present in a little bit atypical way compared with the typical patient with chest pain? So what's your view on that?
Okay, thank you for your questions. For the first question, with woman patient, female patient, sometimes we don't have the typical angina. And I think the cardiologist should keep in mind the diagnosis of CAD if the patient is in high risk, like this patient with hypertensive, dyslipidemia, and diabetes. And based on this suspicion, I think we should think further about the further investigation for this patient, as I mentioned in my case. For the second question, in thinking how to choose the which test we can do in this kind of patient, as I mentioned in my case, I CCTA in this patient because you know, in the EKG, rest EKG, the patient don't have any specific STT, depression or something like that. And moreover, the patient is obese, and she can't she can't do any exercise if we do some stress test for her. So I would choose. I would prefer the CCTA for the further investigation of her suspicion of CAD. Yeah.
Yeah, no, I totally agree with you. And do you want to comment on the role of the treadmill test in this specific type of patients? I know that we use it and sometimes just to see what is the reaction to exercise and if you can stimulate some sort of ischemia. But do you think that maybe in this type of cases, the use of the treadmill test may not be so useful, or do you think it's useful and still should be considered as in the diagnostic scale of this specific type of patient?
Sorry, teacher. Would you please repeat your question?
And I was discussing a little bit about the role of the treadmill test in the setting of patients who present with angina equivalent. Of course, we do it, and as you've done it. But my question many times is how useful it is, if maybe from a diagnostic standpoint, it shouldn't be more efficient if we go to a CTA, so we can, with that CTA, either exclude or have suspicion of coronary disease, and the treadmill test here maybe is a little bit overused or not. So that's a little bit the role of, in your practice, of the treadmill, particularly in patients who we suspect are angina equivalents who don't have the typical chest pain. Yeah,
we know that the CCTA is the anatomic test, and the treadmill test is the functional test for the CAD. And in my experience, I think the treadmill test is not suitable for the lady with obesity and with the sedentary lifestyle like that, because sometimes if we indicate the treadmill test, we can have the uninterpreted answer result. And in such a case, if I choose some functional test, I would prefer to indicate maybe the MRI stress rather than treadmill test, stress echocardiography, because she is obese and the echogenic maybe not in high quality image for the echocardiography, for the stress test. Yeah, I think if the patient still complains about her discomfort in the chest pain or like dyspnea, I will convince her to do the coronary invasive coronary angiography. Yeah.
Very good. You included in your treatment, when you modified the medical treatment, ivabradine, which is one of the alternatives that we have, or options that we have, particularly if the patient has still a high heart rate. My question to you is, in your practice, do you first try to up titrate the beta blocker, or you do the combination from an earlier stage so you can use lower dosage of beta blocker together with ivabradine? So what's your experience, and how do you use particularly the combination of a beta blocker with ivabradine in this specific setting?
Yeah, normally in controlled heartbeat, we have some studies that shows that it would be better if we add ivabradine rather than increase the dose of the beta blocker. Yeah, and in my experience, for this case, I increase also the beta blocker and I add ivabradine because there are some benefits with the ivabradine in the reduce the symptom, reduce the frequencies of the symptoms like dyspnea or angina. So I would rather add the ivabradine in parallel with the beta blocker. Yeah.
Very good. Well, thank you so much, Dr. Tan.